Welcome to Ivy League, everyone. I'm Tony. We are here in Denver getting ready for the AVA conference. Hopefully, we'll get to see some of you out here in a couple of days. I am going to go ahead and pass it over to Kristen so she can introduce our speaker today, Dr. Kristen Jacobs.
Wonderful. Welcome, everybody. We're here with Josh Stewart. Welcome, Josh. He's a vascular clinical specialist for BD, and he has a background in emergency room nursing. Welcome. And today your topic is PIV excellence education. So I'm going to pass it to you.
Awesome. Thank you so much. I will just hit share at this point and see if I can figure this out for a second time. Can everybody see this? Perfecto. Okay. Awesome. Well, again, I'm Josh. Like it was already said, I have a background in emergency department medicine. I am a nurse. After the emergency department, I moved on to vascular access, as many emergency department people do. And from there, I now work for BD as an educator in really all things vascular access. Thank you so much for not reading that whole bio, because Gretchen, who's also on the call, was like, Josh, you really need to write a bio about yourself. And I just don't like talking about myself like that in any way, shape, or form. But all of that being said, I will say that I see the irony in the fact that a lot of the times the emergency department clinicians are the ones that are the biggest offenders in terms of placing the largest line because it's a pride thing, or placing it in the AC because that's the easiest spot to go. And I'm sitting here talking about what's best for IV excellence. But again, I have switched over to the light side in terms of vascular access, and I do have quite a few years under my belt related to that subject. So what are we talking about today? So IV excellence education. We have two new resources that are going to be available to be utilized should anybody want to use these resources, to really just help out in terms of teaching all clinicians within a hospital setting about best IV practice. We are going to be offering an IV Excellence interactive PDF. Essentially, it is all things related to INS standards with PIVCs specifically. It's not really touching on central lines or anything like that. But the nice thing is that it comes with pictures. And if you're anything like me and have ADHD, pictures always help because it makes up for a lot of the very small words that are next to said photos. The other great thing about the PDF, and we'll get into it, but it does have hyperlinks within it so that we can get more information out of it. The second thing we'll be talking about is the IV Excellence PowerPoint that we're offering. It is going to just be a classroom setting, and I will further discuss in a couple of minutes just how this slideshow is utilized and what other parts of it come into play. Before I do that, let's talk about the burden of the problem. And when we're looking at this slide, if you guys can read this with all of these small words, I'm very, very impressed. My eyesight is not as good as yours in that instance. But I think that the main takeaway from all of it is that IV placement is known to be one of the highest utilized invasive procedures within a hospital setting. I would argue that it is the most highly utilized invasive procedure within a hospital setting. And yet, despite that, it's probably one of the most undereducated. A couple of the key points, and I am reading these key points because I'll be honest with you, there's a lot of numbers on this slide and I have not memorized all of them. But of the patients that do receive IVs, overall, there's about 400 million PIVs sold in the US every year. And in terms of patients, about 90% of all hospitalized patients receive some form of vascular access. Of that 90%, around 50% of those patients require a replacement of their IV before the completion of their therapy. And why is that? It's a lot of reasons, obviously, but oftentimes it's because of inappropriate device selections. So wrong line at the wrong time instead of right line at the right time, so to speak. There's the inappropriate placements in that they are placed in suboptimal locations, such as the AC or the wrist, a place where there's points of flexion. And then for the established lines that are already in the arm and they end up on a floor somewhere, there's the inappropriate care and maintenance. So once the line is in, people don't really know how to keep that line healthy for the duration of the patient's stay. There's also the forever fought against variance in hospital policies and like variance in belief of best practice. And that's really huge because whether you're talking about hospitals within the same system or just different systems, all with different beliefs, essentially people kind of go with their gut a lot of the time when they don't know what INS is saying in terms of best practice. And that's a problem because we are not all teaching from the same book, so to speak. And on top of all of this, and everybody on this call, I am sure is aware of this, but really depending on where you work, we all know, especially because we all are the end call in these scenarios, a lot of the times greater than 50% of the patient population are DIVA patients, and that's a problem. Anecdotally, when we all first became nurses or clinicians, when we all first started placing IVs, where did you guys all learn your IVs from? You didn't learn it from a classroom setting. You most likely didn't learn it in nursing school. For myself, I learned from my preceptor, who learned from her preceptor, who learned from hers, and so on and so forth. And what we end up with is IV practices that are, 15 years behind the times of what we now know is best current practice in terms of vascular access. Now, breaking it down a little bit, and I promise this is a relatively short presentation, so there's going to be time to discuss this later on if you guys have questions, comments, concerns. I'm absolutely open to discuss anything that anybody wants to discuss, but I'm just going to break down essentially these two learning pieces that we now have. I'm going to start with the IV Excellence PowerPoint classroom presentation. The first thing that I'm going to say, and I really feel that this is important, is that this coursework, this classroom presentation, there's a group of people that it's really not going to affect that much. And that group of people are the people that are on the call right now. The fact that you're all sitting here, sitting through a hurricane, maybe missing dinner or eating dinner, you're on shift. I saw that, Philippa. You guys are taking the time out of your day in order to learn about best IV practice by having these little micro learnings that AVA is producing, which is phenomenal. But because you are actively trying to get to the best practice within your field, this sort of classroom setting is not meant for you. It's really meant more for the clinicians that are showing up to take care of their patients, but they really don't know the first thing about IVs or what good IV health looks like. When are we going to use this sort of coursework material? So I can read you the bullet points, but I know that you all can read, but hospital competencies, new hire onboarding, or if there's a change in the IV product. I've taught this class a lot across the United States, and what I have found is that even if a hospital doesn't have a system-wide hits every floor sort of competency where every nurse every year has to go through a series of stations to get signed off on different skills, we at least know that the highest stick units, such as the ICU or the emergency department, because those are units that have higher levels of care where they have to take care of trachs or infusing Levophed, things like that, those units are having competencies yearly. And the goal is that if we can't hit every clinician within a hospital, it's really, really great to at least bring this into the competencies for the units that are placing the most IV lines. And I am really going to, heavily harp on the emergency department with that one. Almost every single patient that ends up on a floor is either coming from pre-op or coming from the emergency department. And those are the people, since they are the first sticks, that really should be learning this sort of material. In terms of the new hire onboarding, I don't know if anybody here has in nursing school received an IV sort of course, but I know that I didn't. I know that that's kind of been avoided recently in the past maybe decade. And we've got brand new baby nurses coming in that do not know the first thing about IVs. They know how to scrub the hub and they know to make sure their medications are compatible. but they don't know how to stick. They don't know good locations. They don't know good dressings. And because during hospital onboarding, there are skills competencies with every onboarding that happens, I think that this sort of coursework is really got a huge opportunity to be brought into that new hire process so that they can at least start off on the right foot. I'm not saying at the end of this class, they're going to be expert stickers, but at least they're going to have a better idea of what it is that they're doing with the IV as they grow and learn within their practice. Obviously, it goes without saying that if you're going to change an IV product, this class would come in really, really handy just because if they're all about to learn about a new IV anyway, we should probably teach them about best vascular access alongside of that. Now, who is it meant for if it's not for you all? And I know that you've probably already read this already, but the key driver here is that we really want anybody that can promote change within their unit on IV health. And obviously, it's important to get the clinicians that are actively working with the patients, but if we can get the leaders that are the people that these clinicians go to when they have a question or go to when something goes wrong, then these leaders will have the knowledge to say, hey, let's go back into this room, let's assess this line, and then let's step outside and discuss what the best next steps are. And they really are the key drivers in change, the educators, the CNSs, the managers. It's really, really important that during a class, those are the people that are actually present, that are listening to the slide deck and listening and participating in the hands-on aspect, because again, they're the ones that can promote change. Now, obviously, I already said this, but getting the bedside clinicians is also important. And if we can't get everybody, like I said, just get the units that are sticking the most. Pre-op, ICU, ED. If we can start there, then we know that the IV help will spread to the rest of the floors like tele, step down, and med surge. Now, in terms of the IV Excellence interactive PDF, I had to read all of that because it's a tongue twister for me. When would this best be utilized? So it works really well as a PDF because the glossary has hyperlinks. So you can click on a specific word within the glossary and it takes you to that specific section of this PDF. If you print it all out, you're going to be flipping through about 30 to 40 pages until you find the section that you're looking for. It's really great just to keep it on the computers on the unit. If you guys have iPads available, or if you have work phones throughout the hospital, having that PDF on that platform is great because it really does help the clinician at bedside to look at a line, notice that this is looking a little red. I wonder what this could be. And they can just click on the glossary, click on the hyperlink of what it is that they're observing, and boom, it gives what it is that they're looking at, what the therapy for that is, and so on and so forth. Going to the next slide. The next slide is really just discussing what the course contents are specific to the PowerPoint classroom setting. So this is what we're covering in terms of contents for the presentation itself. We talk about what the current status of PIV practice is. In fact, the first slide that you all looked at with all of those words is the very first slide also within that presentation. It also talks about infusion considerations. You see that graph that you've seen a million times over in so many other textbooks where it shows the pH scale and what acidic versus basic is. Actually, one of the things that I love to bring up on that slide myself is that who knows what the average pH of normal saline is, right? Because it's actually 5.5. It's actually, as an average, an acidic medication. And yet we always are infusing normal saline into patients and going, well, why did that line blow? All I did for the past 4 or 5 days was normal saline. Clearly, this is a line issue. There's no way it's because something that is essentially Gatorade for the veins is infusing in there. It's just water, right? But I always get a couple of eyebrow raises when I bring that up and people go, oh, wow, I didn't even know that. We get into venous anatomy. We talk about the different layers of the vein and what each layer is comprised of and essentially what its function is within the vein. And the big one that I really spend a lot of time on are the slides that are associated with right line for the right time. I think it's so important that we start teaching that the biggest line is not the best line, that if we're done with all of the studies that we have to do in terms of CAT scan or MRI or anything related to pressure injection, if a person needs a new line and we're just doing antibiotics for the next couple of days, why aren't we placing that 22 gauge? Why aren't we giving the best sort of hemodilution? The other thing that we discuss within the slide deck is ANTT, as well as just appropriate dressing placement overall. I know the swear word among vet nurses is Coban, and definitely I spend a lot of time during the slide deck talking about why that's not great for the patient. We're also obviously talking about location considerations, the angle of insertion, the flushing sequences, depending on what needleless connector is connected to the back end of the IV, all of the basic information pieces that we as vet nurses are well aware of and are well studied up on, but things that really are never discussed in terms of with bedside clinicians that do not focus on a vascular aspect. I think one of the biggest things to get across during the slide deck is also that when you're doing a full body assessment on a patient, it's not just looking at the IV line and going, cool, it's still infusing, but actually knowing how to assess the line past the point of the medication is still going in. The final portion of the slide deck is going through all of the major complications that can happen with a PIVC. And that's really, really huge because not only do we talk about and have pictures within the slide deck of what each complication looks like, but we also have descriptions of how to treat that complication depending on the scenario. The second half of the presentation, and I forgot to mention this in the beginning of this, I apologize, but for this presentation, when we created it, I was hoping that all said and done, the presentation would be about an hour long. But what I have found is that really it's about 45 minutes of slides and then 45 minutes of hands-on, just because so many people have so many questions afterwards. But the hands-on portion of this is equally as important because we teach the physical ANTT. We don't just talk about it, we show an example of it. There's also the correct placement of the IV line. And obviously ANTT has a part to play in that, but I also make it a point during the hands-on education to discuss, hey, you're not getting enough of the length of the IV catheter in the vein, and that's a problem. If you've ever wondered why CT is saying your line blew and you want to blame CT, chances are it's actually not their fault, right? And then obviously we are, with the hands-on aspect, also going to be promoting how to appropriately attach the extension set. And again, how to appropriately place the dressing, not stretching it out and pressing it to the skin as hard as we can, and then taking an entire roll of plastic tape and wrapping it around the arm so that that dressing stays in place. After we do the hands-on as a form of education, the follow-up is going to be making sure that we observe everybody in the class. Do the return demonstration, because it's one thing to see it, it's another one to do it. So that is the gist of the IV Excellence Classroom features. And like I said, don't forget that we also have that PDF booklet. Again, I would recommend keeping that on a digital platform so that you've got the hyperlink buttons available. But those are the two new features that are now available to everybody that may want them, should you all be interested. And this next slide that I have is really something that I just found fascinating, and it is a portion of the slide deck for the education piece. You already heard me reference it a little tiny bit, but it's the vessel purchase of the length of the IV catheter and why it's so important to get the majority of the length in the vein and not just in the tissue. So this is just a phenomenal representation of, if you don't have enough of the catheter in the vessel, then that catheter is going to fire hose its way out. And I just love this X-ray, or this, it's obviously not an X-ray, but I love this video because it really does give a great representation of, if you've stuck the entire needle in somebody's arm and you only got a flash if with 10% of the length of the catheter sticking outside of the skin, that means you've only got 10% of the catheter actually in the vessel. But I also love this video just because it shows what's going on in the arm when we're not performing best IV practice. Like I said, this was really not a long presentation that I had for you all. We just wanted to show you guys what's now available should anybody here want to take this on and utilize it within your hospital setting. Like I said, this slide deck is recorded, obviously. I can see that now that I'm still being recorded, but if you guys ever need to, go back through the recording and go, how was it that he said to utilize this sort of material again, it's all on the slides. But I really do feel that it's important to start getting to leadership within hospitals outside of the VAT setting, so that instead of the 4 people on the team in the windowless office that is essentially a closet that are the only ones that know about best IV health, we can really at least start the right steps in the right direction for getting everybody within the hospital squared away with at least best IV practice. Obviously, central lines is a completely different can of worms, but this is a start, and I really do think that this is important to start getting out to everybody. And I'm just stop hitting play on this. I do have written down a couple of metrics for you all. I have it highlighted. Does it work? So this is a newer program. I have not been able to do a ton of analytical research yet, just because the availability has not been there yet, or if we've seen positive turnarounds for hospitals that have utilized the presentation and utilized the PDF. But we did recently do a hospital evaluation about 5 months ago to see what their current IV dwell times were and what the overall health of the IVs were. And at that time, they had about a 58-hour, I think that's like what, 2.4 days? They had a 58-hour average IV dwell time. And we gave them the IV Excellence course. I actually was one of the ones that presented it for several weeks. We were able to hit them within their competency setting. They did have hospital-wide competencies. So we were able to talk to every single clinician that actually worked in the facility. And after we gave all of this coursework, about a month later, we did a reevaluation where we captured the same metrics, and they actually increased their IV dwell time from that 58 hours to 97 hours for an IV dwell time, with no change in anything else other than the coursework that I've been describing here on this slide. So that's an increase in IV dwell time by 67.25%, which I think is pretty great. And I'm hoping that that's what continues, hopefully across the US with this sort of course material. But that is essentially all I have for everybody here. I am sorry if that was too short and sweet, everybody, but that is what I have. And this is where I sit here and say, does anybody have any questions?
That was perfect, Josh. Perfect time.
Awesome. Thank you.
I will say we know from our personal experiences in the facilities that education is needed. It's not even a matter of does
Yes.
this specifically work? Like, we know from what we see, we all have horror stories, that education is definitely needed. I know we at AVA have a program that we are working on trying to get into every school possible, to speak to what you said, where schools are not teaching it. We are in 29 schools so far, hopefully, and counting. If anybody's attached to any schools, please see about getting that program in for them. But we need it in the facilities, because we have so many nurses who did come out of school, whether they've been a nurse for 50 years or they've been a nurse for 5 seconds. Everybody needs the education on PIVs. So definitely an important thing we need to see about getting into where we are.
And one of the things that I'll add to that is, I was about to say, when I created this, there was a lot of people that created this, but I was spearheading it a little bit. I'll at least say that. But I spoke with a lot of hospitals, and of the hospitals that said that they were teaching an IV class, the biggest thing that I found is that their IV class was 4 hours long, 3 hours long. It was a long time. And I don't think that capturing all of the clinicians within a facility with a class that long, A, is feasible, but B, even if you do, you're going to lose interest very, very quickly. And it's why this setup was put together the way that it was. I said that I tried to make it an hour. Realistically, it's an hour and a half. But I was trying to make it as short and sweet as possible because I just want to get the key things that get people thinking past that point. But at least if we can get them started with the most important parts, that's going to be what really drives change. Is if we can at least change the fact that they're not using Coban anymore, or they're not putting hard plastic tape over the insertion site of the IV dressing. If we can change that little stuff, we know that the outcomes for the patients are going to be better off. And I do like the whole short and sweet aspect of what this form of the curriculum can offer. Tony, I know that you and I were talking about PC monitors, but the other thing that I found on Amazon when related to this class is that you can actually buy a vein arm with a blood bag where like you can actually palpate the vein. Again, $75. I mean, if the hospital can afford a couple of those things for a classroom setting like this, like it's there, and you don't have to pay an arm and a leg, but you don't have to pay an arm and a leg for the arm, you know? So it's all of this stuff is very doable in different scenarios like the ones that I was mentioning.
To answer Greta's question, she asked, she missed the first part. She was hoping to learn more about the class. This presentation will be available on the Ivy League platform on the AVA site tomorrow. As I said, when we started, I'm out in Denver at the conference, but I will get that up there as quick as possible. I'll try to make sure I get it done tomorrow morning. So you can watch the beginning again, or else you can go to BD, I'm assuming, and
Absolutely.
find out about the IVC Excellence Program. So.
And then Gretchen, there's the chat. I'm just gonna do this. I'm gonna type my email in because I have access to all of this stuff. If anybody, I'm not going to say that I am full of time, but I can make time. If anybody wants to talk about this further and wants to see how I present it out and you just want to talk, I'm open to it. So I'm going to put my email in here. Just shoot me an email and I am more than willing to get a little bit more detailed into the classroom aspect of like how I present it out, how I set up the hands-on portion of it. If anybody is interested, I'm available. I am typing that in now.
Monica asked, how do we get it into Epic or on the Rover phones?
Great question. So I don't know the answer to that. BD has online learning modules as well. And we do actually now also offer new modules related to IV health that correlate essentially side by side with the presentation material in person. All I know is that with the hospitals that I have helped get those modules into, it is all on the hospital side and working with whoever is in charge of Epic or the learning portals that all of the different hospitals have. As long as you get to the right person, you can give them the information and they can get it uploaded. But also remember, I mean, I tend to keep a ton of stuff just on my personal phone as well. If it's something that you want to carry around with yourself, so if you're looking at an IV line and you want to take that time to pull a nurse aside and say, hey, what do you think you're looking at on this patient's arm? You know, walk out of the room, don't do it in front of the patient. But you can always just open up your phone and click on the PDF there because we can, again, I sent you my email. I'd be happy to send the PDF in your direction if you just want that copy.
Now, I know that BD has the, I'm going to say this wrong, Infusate Consideration Companion, the app,
Actually, yep.
app that is magical.
Yep.
Is this eventually going to be an app or something readily accessible?
Great question. Gretchen? No, so
it is an app.
It is an app. Oh, amazing.
Yeah, so actually within the slide deck, I will show it to you instead of, I'm gonna stop sharing my screen really quick here.
Oh, I already stopped.
Oh, I already did. Perfect. Okay. I had it pulled up just in case of this. So
and
I've
said IT can help connect things to your Epic and your Rovers. So reaching out to IT might be helpful.
Yeah, definitely.
Hey, Tanya,
Share.
am I off mute?
Nope, you are on mute, or I can hear you.
Okay. I was going to say some of the things that I've done as an educator is to get apps and things on. Every facility should have an IT contact that can help you. Epic has its own education area in Epic, and they can help you with that. If you use Elsevier, you can also, some of your professional practice people or IT can help you get stuff uploaded to Elsevier. It has to be approved by Elsevier first, and to get it on your Rover phones, because we've had a lot of apps added to ours.
And I'm only sharing my screen now just because this is actually one of the slides from the classroom material, but it is literally what we were just talking about with the Infuse-It companion. As for the PDF and as for the PowerPoint presentation itself, that's not on an app yet, but I know that BD is talking about creating a QR code, just like there's one for the Infuse-It companion for the PowerPoint and the PDF as well. And I'll stop sharing my screen. I just wanted to show everybody that if they wanted to scan it right now for the Infuse-It companion, tell me to not stop sharing, but it's here.
For those who are doing infusions and aren't using the infusion companion, you need to get on that. That was one of my favorite tools when I was bedside.
Yep.
And even putting lines in, being able to look at that and be like, oh no, you need a central line, or this one isn't appropriate for that. It really, really is a great tool.
It is. And I'll say that our online modules are great, but if anybody remembers or if anybody is still doing online modules, you know that you're not doing it on your off time, you're doing it while you're working. And while you're working, it's skip to the end and then take the quiz, right? It's why I think that the reintroduction of going old school and going back to the classroom setting is so important, because you've got their attention then, you know? And I really can't stress enough the success I've seen with it so far, and just it's really been interesting to see so many people that I just would have assumed didn't care and go, wow, I've never considered this or that before related to IBs. It's never even been something brought to my attention. And it's really made a change in the places where we've been able to offer this so far.
I'm waiting for them to come up with the official term for online module education fatigue, like they did alarm fatigue.
Alarm fatigue, yeah.
It is. Okay, does anybody else have any questions for us? Then if not, we are going to let you have your evenings back. Everybody have a great day. Stay safe. I know a lot of people are dealing with some crazy weather and fires and all of the earthly things. And hopefully we'll get to see some of you in Denver in the next couple of days. Everybody have a good night.
See ya.
Thanks, everybody. Have a great night.
Thank you.